conference. And then hopefully we'll still have a little time for some small groups, but we'll see. We'll see. If the AMA goes long, we may just wind up ending here. So my talk today is good, better, best, envisioning the future. Just to remind everyone, in case you weren't aware, Angioma Alliance has a mission. And our mission is and has been for a number of years now to inform, support, and empower those affected by cavernous angioma and drive research for two different things. And I'm going to emphasize that these are two different things: better treatments and a cure. When we talk about the life of someone who has cavernous angioma, the families that are affected, it's not just, do I have a pill today? There's a big picture life that falls into a big set of concerns that come with the illness. And I want to just quickly go through what those things are and how they affect each of us. First comes diagnosis. And I'm going to sort of walk you through the years for how that has changed and how I hope it changes in the future. But diagnosis is really important and really the first step that people take in this illness journey. Then trying to figure out, is there a way for me to track or predict this disease so that I can make some good decisions about how to go about care? Do I get surgery? Do I do medications? Do I just sit and wait? What do I do? What options are there for treating? Are there medicines? Is there surgery? Is radiosurgery a good idea? Are there multi-systemic impacts of the illness that I should be concerned about? So this is new. What I'm talking about here are, does the hereditary form of the illness cause scoliosis? Does it cause changes in the gut? Does it cause lesions in the adrenal glands? Does it cause skin lesions? The answers to all of those are yeah. And it can, depending on what mutation you have. Recovery and restoration, you guys just now know more about rehab than I will ever know because you just heard two talks that I didn't get to hear. So I'm not going to go deeply into the recovery and rehab because I'm going to just say stupid things that you know better than me. But that is obviously an aspect. There are a lot of folks who have the illness, have the surgery, are actually lesion-free, but continue to be part of a Angioma Alliance because it's not over. And it never is over for those who are still learning to live with the deficits. Then we have comprehensive clinical care. How easy is it for you to find people who know what they're doing in the medical community? When is it appropriate for you to go and seek care? When do you need to see a specialist? When can you actually make do with just your PCP? And then finally, it's the supportive community that we want each of you to have, that Angioma Alliance is part of, but that we hope will grow even beyond us. So I'm going to take a quick walk through the years. 2006 for me was a year that was a changing point. Angioma Alliance started in 2002, so that was the beginning of that. But in 2006, by then the third gene had been identified. We were holding our second international scientific meeting, so it wasn't just a one-time thing. It became like a trend at that point. We opened up a DNA and a tissue bank, so we became active participants in research. And so 2006 marked a turn, but there was so much work to do in front of us. So at that point, what I would hear most often from our patients was, I went to my doctor, he sent me first to the psychiatrist to try and figure out what was wrong with me. Okay, so I'm sitting like nodding here. There's a lot of nodding. I got sent to the psychiatrist first because it was all psychosomatic, I was told, and I needed to work through my issues in order to get to the right diagnosis. So then that didn't work. Surprise, surprise. And I wound up back at the doctor, and I wound up with a neurologist who worked me up for MS or something else that was bizarrely different from what actually was going on. And then finally, I wound up with the right doctor who had a suspicion that maybe I needed an MRI. And so I laid in the tube for about 45 minutes, and I waited 3 weeks for the results. Or first they told me it was a cancer, it was a big tumor, you got a tumor in your brain. And then finally, somebody who even better knew what they were doing told me that it was CCM, cavernous angioma, cavernous angioma, or cavernous malformation, depending on what the doctor of the day was going to call it. But then they told me, well, just go out and live your life. Because that's all we can do for you right now. You're not operable, just go on and live your life. Or they told me, and this is the next bullet point there, few natural history studies where go on and live your life because we don't know what the heck is going to happen to you. The next one is, we'll go have it taken out. But if you're going to go have it taken out, make sure you go to Phoenix, because Dr. Robert Spessler is there. He's the only one you want to have touch you. So there was really only one surgeon, maybe 2 or 3 surgeons in 2006 who were the go-to people for the illness. And if you didn't go, and if you were lucky enough to learn about them, mostly you learn about it through Angioma Alliance, sometimes other surgeons referred. That was where you wound up. People were getting radiosurgery regularly. If anything, 2006 was kind of the heyday of radiosurgery because they had decreased the dosages, but they thought made it safer, but they still didn't really understand that, especially if you have the hereditary form, it's a bad thing to do because you develop more lesions as a result of having a radiosurgery than what you got taken away. 2006, what multisystemic effects? This is a brain disease, and it is only a brain or a spinal cord disease. Rehab was very basic. There was mechanics, and again, I'm not going to talk about it because you know more than I do now. What prevention? How can you stop these things from ever hemorrhaging? How can you stop these from being transmitted to the next generation? There was no even conception that that was possible. As I said, just a few knowledgeable surgeons, very few treatment options, and our patient community existed, but that was, believe it or not, before Facebook. There was a world before Facebook. And we did talk to each other on the online community forum on our website, which still exists, because there are people who are not on Facebook. But we certainly weren't as well connected as we are now with the social media options that we have. So we had more questions than answers. Where are we now? So now you can go to a doctor and pretty regularly get diagnosed within a few weeks of having some significant symptoms, because now folks are more often referred for MRI than what they had been before. And if you're lucky, you get an MRI with an SWI sequence that even if you don't get it the first time, more and more people are getting it at least the second time. The SWI sequence will help the doctor, if you know what they're doing, figure out whether or not you have a hereditary form. If there's only one lesion on an SWI sequence, then you do not have the hereditary form. You do not need genetic testing. What was that?
Or DBA.
If you have a DBA, yes. If you haven't had brain radiation and you don't have a DBA, and you only have one lesion. If your lesions are clustered around your DBA, you have the sporadic form. If you have multiple lesions all over your brain, you have the hereditary form. You need testing. If you need testing, now Angioma Alliance can make that happen for you. We would like insurance to make that happen for you a little bit more, but in the meantime, we're taking care of it. We do understand natural history better. We do know that you are most likely to have a second hemorrhage within 2 to 5 years of your first hemorrhage. We do know that if you got diagnosed as a result of an MRI that you had for something completely unrelated, you have a small lesion that has never bled, 99% of the time, it never will bleed. So your old doctor's advice that we used to roll our eyes at of go live your life is actually in those cases not necessarily the worst advice. Because for the most part, this is a silent disease and doesn't act up if you have just one lesion and it's never hemorrhaged. We understand the genetics better in that we know that there are differences between CCM1 and 2 versus CCM3. We know that one lesion on SWI means you don't have the hereditary form. And we know that there are different rates of proliferation between the different mutations of new lesion development. We have a little bit more treatment options, not enough by any measure, but now some physicians are practicing some minimally invasive surgeries and vitamin D. I know Dr. Fleming talked about it yesterday. It may be helpful. We'll never have a controlled study because there's a sun, there's a sun. There's no way to have control. But we do believe that it may be helpful. And we're beginning to identify, I gave you that laundry list of possible multisystemic issues. We're beginning to identify what they are. We're beginning to understand a little bit what is causing them in relation to the genetic defects and understand what the consequences are on the illness and on the individual. We also have more informed PT, OT, surgery options for recovery, orthotics, robotics, different ways of recovering. For prevention of transmission of the illness to the next generation, more and more of our families are choosing IVF with PGD, which means in vitro fertilization with pre-implantation diagnosis, so you can have a genetic probe of an embryo to determine whether or not it has the mutation, and choose to implant only those embryos that do not. One of the caveats of that is that if you're a woman with a genetic form of the illness, sometimes the fertility treatments involved in an IVF and getting to the point of having an IVF procedure can precipitate bad things to the brain illness. But if you are the male partner involved, this certainly is a decent option if it's something that's within your belief system. For care, you don't just have to go to Phoenix anymore, and he's retired anyway. So 7 U.S. clinical care centers are recognized by us. We will be bringing more online. We would have more now if folks would just send their applications in. There's some very busy surgeons out there that are, honestly, the issue is more in the neurology departments being too diverse, and they're not being able to identify 2 or 3 neurologists that could be the key people. But I know that we have at least 3 other places where as soon as they submit, have their teams together, they will get the stamp of approval from us. And community, we have Facebook. We can find each other, we can offer support, we participate together in advocacy research and raising funds. Yay! So how did we get here? We got here because we participated in studies that allowed scientists to identify the genes. We are getting genetic testing more and more, and I'll talk about this a little bit at the very end. We have this annual scientific meeting that has helped to form collaborations that Dr. Watt talked about yesterday at lunch, but they are international, they are huge, they bring in lots of acclaim and grant funding from the NIH, and they all started here. Our DNA and tissue bank that anybody who's had surgery, or many people who've had surgery, have donated their tissue to, has advanced the science. Our efforts at legislation and advocacy have been very important in making us a priority at NIH. We have had natural history studies, the one in Scotland that Dr. Salmon has been running since 1999, and then the BBMC project that is in its 9th year, that some of you may already be participating in here, because Angioma Alliance is a partner in that one. Those have helped us understand what to expect. Our centers of excellence were developed by Angioma Alliance, and our community is you guys. And so, what's the commonality here? It's you! The commonality is that you are awesome. The reason that all of this has happened is because you have made it happen. And I thank Stephanie for this.
You won't let that one.
You are awesome. And that is how we are going to move forward. It's because of us. We don't move forward because of the researchers. We don't move forward because of the doctors. We move forward because we make it happen. If we're not making it happen, it's not going to happen. So what are we looking forward to? Now, I say 2024, and you guys are like rolling your eyes probably and going, that's such a long time from now. So think about it this way. We're about to go into 2019. 2024 is 5 years from now. 5 years ago was 2014. Like, that was yesterday to me. I don't know about you, but it was yesterday. And there will be incremental things. Each of these things that I'm about to mention are going to advance incrementally along the way. So in 2024, my dream is that we will have urine biomarkers that will be able to tell us whether or not we have a lesion. So somebody can walk into an emergency room, pee in a cup, and be told, yes, you have a vascular malformation. They may not know what kind it is, but they may be able to tell you at that point because of some work that's happening at Boston Children's that, yeah, you got, there's something going on out there that we need to follow up on, and it's not a non-invasive way. We may have blood biomarkers that will be able to tell us whether or not you have a hemorrhage. That's one of the things that Dr. Watt's group is working on. Did you have a hemorrhage? Let's check your blood and find out. Not let's do an MRI or put you in a CT scan. Let's just do a little blood test and find out. We hope that genetic testing will be covered by insurance, and I'm hoping for shorter MRIs personally, because staying still for 50 minutes or more is just ridiculous. Accurate course prediction, again, another set of blood biomarkers will be there, we think, to help predict who's going to be most at risk for hemorrhage in the next year. Like, that would be cool. You could go to the doctor, get a blood draw, and the doctor would say, you're good to go for the year. Come on back a year from now. Don't worry about hemorrhage for this year because you're fine. We at this point are now, he's kind of like doing the end part of testing on that, trying to tweak it a little bit, adding some different biomarkers in just to make sure he's got it 100% perfect, but that's not that far down the line. That also plays a role in treatment. If you're not at risk for the next year, do you take the medicine? It depends on the medication. Maybe you don't have to take the medicine that year, but if you find out you are, that would be the great year to start the medication, whatever it turns out to be. Imaging biomarkers too will become more important, and by that, you heard the other day or yesterday about QSM. That's the measurement of iron in the brain and the lesions, and permeability, the weakness of the blood vessels that are in your brain. We will, by 2024, have at least one approved medicine that will at least mitigate somewhat the effects of this illness. And what we're looking at are medicines to stabilize vessels, to reduce the risk of hemorrhage, to reduce the number of lesions that develop in the hereditary forms. And also, this has become more and more of an issue, I feel, to reduce the recurrence of lesions after surgery. A lot of folks lately have been having surgeries and the lesions grow back. I think that's because there's been more aggressive surgeries that have been, there have been surgeries done on lesions that were previously inaccessible, but the surgeons could not be so aggressive because it would cause more problems than solve them. And so there have been recurrences more often I see them. And we should have some ability to reduce the impact of multisystemic disease. They're doing stem cell therapy right now at Stanford for people with ischemic stroke who have brain disease, brain trauma, brain damage as a result of ischemic stroke. Dr. Steinberg has assured me that once the ischemic stroke studies are done, he's moving on to hemorrhagic stroke. So by 2024, we will have a very good idea as to whether stem cell therapy might be an option in addition to the other things that can be done for rehab. We may be able to prevent recurrence of hemorrhage in more natural ways, but also even prevent more easily the transmission of the illness to the next generation in a way that causes problems in the next generation. So what I'm saying here is that there may be a CCM diet at some point that will, if you give it early enough, can prevent the proliferation or development of more lesions. Or if you give it later in adult life, if you follow the CCM diet, you may be less likely to have hemorrhage. In the mouse models, this is dating back about a year, in the mouse models, when they were able to clean up the guts of the mice, the children of those mice did not develop lesions. So the mice that didn't have the genetic defect and didn't develop lesions because their guts were clean had babies who did not develop lesions. So I don't know how much this is going to apply to humans. This is still very, very early, but wow, wouldn't that be awesome? So I could see a day when there is a CCM diet. I could see a day too when IVF with PGD becomes a cheaper, more affordable option for our families. We by then, in 5 years from now, should have many clinical centers, and we'll have them all over the world. And we will have a community that is organized and mobilized, and that to me now is the big word, mobilized for research participation, fundraising, awareness raising, outreach to clinicians, outreach to other patients. I can't do it by myself. Stephanie is a huge help. Stephanie is amazing. Stephanie can't do it by herself though. And Amy is wonderful, but she can't do it by herself either. We need an entire community of people working for us. So the path to the future for 2024 is everyone needs to participate if they can, or support people who are participating in clinical trials and other clinical research. Join the patient registry, get genetic testing, educate your friends and family about the illness. Support research by supporting our scientific meeting. We're going to be doing advocacy. There will be grants, hopefully that we're able to give out to specific researchers. Form many community alliances, and also importantly, increase international patient participation in research. There is no way that we have enough people in the United States to fill all the clinical trials that we're going to have. We've got 9, 10, 12 drugs as a result of this week in the pipeline. We can't test all of them using just US people. We need a whole world worth of people, and let me show you why. We, in North America, this is not just like US, this is all of North America, we're third on the list in terms of the population. If we start looking at Europe, Africa, and especially Asia, we can increase the capacity to do clinical trials so much. Europe, we're already partnering with. We're also partnering in South America. There's a pretty active group in Brazil. I'm going to be going down there in August to help with their first scientific meeting. And Europe, Jana, who is in our board meeting right now, is planning to bring together a consortium of European patient advocacy groups. So we're working on it, and we have to work on it. We don't have any, it's not like we have a choice. This has to happen in order for us to get to 2024. So better treatments are good. That is an important step, but better treatments are not yet the end game. They are not the goal, they're not the final destination, because they're not the cure. What we want to get to eventually, but here I put 2030, and again, think back, it's 12 years from now, 11 years from now, where were you 11 years ago in 2008? You know, it wasn't that long ago. This is not that far in the future. What we want then is for somebody to walk into the ER, into their PCP's office, pee in a cup, get diagnosed, get thrown into the MRI machine right away for 10 minutes, get told what's in their brain, spend $200 doing it, and then go get their blood drawn or spit in a tube for a $50 genetic test to find out what the mutation is. We would like, again, the PCPs to be able to just draw some blood and let you know whether you're due for a checkup in a year or whether you need to be coming back more often. And we would like to obliterate lesions with no recurrence or side effects using a low-cost, one-time medication or non-invasive treatment. That is what cure is. Cure is a little bit beyond having better treatments, and we can get there. We need to walk our way through better treatments, but I don't think this is impossible. There are already people working on this problem. Everything I'm telling you about, someone is already thinking about. And we might need to help them in a lot of ways, but it's coming. That would be our silver bullet. So by 2030, I hope that we eliminate the multisystemic impacts. I hope that we have a way to restore lost function in people who have been affected by hemorrhages or surgeries in the past. But I also hope that for those of us who have children who were affected before they even had the chance to develop in some ways, that our kids have an option. Doesn't mean they have to take up on it, but that they have an option for treatments that may help them to at least ameliorate some of the deficits that they might be experiencing as a result of not having developed things. I'm also hoping for societal microbiome changes. This is like big sky. I don't want CCM diet. I want to not have to spend 2 hours cooking my dinner in order to make sure I have the right foods in it. I want to be able to go on to the freezer section in the store and buy things that are healthy and that are easy. And then there will probably be at that point gene therapy to prevent transmission to the next generation, and hopefully it will be safe and relatively inexpensive. Informed providers everywhere, including primary care, will be known in all medical settings and among the general public, and the cure, prevention, and restorative treatments will be readily available. Why is this important to me? This is why it's important to me. This is my daughter. That's when she was 11, and that was just a few days ago on Halloween. She didn't have a chance. I mean, she had her first brain surgery at 4 months. She had 4 brain surgeries before she was 4. She's given that. She's doing wonderfully. By 2030, she's going to be 30 years old. Her life could be really different by then. Her children's lives, because she has a CCM3 mutation, each of her children have a 50-50 chance of inheriting this illness. I want her children's lives to be immensely different from what she experienced when she was young. So personally for me also, oh my God, I can retire. I'll be like 68 years old by then. So it'll be time for me to just hang up the saddle and spurs and hat and move on. So the question is, how do we get there? So we do all the same things we're doing right now. We go for better treatments, we participate, we organize, we mobilize. But at the same time, we need to be thinking about the long game. And the reason for that is because I think in every disease, there's a recognition that pharmaceutical companies and cures may not be the best match because there isn't necessarily the kind of return on investment for a cure as there is for a chronic treatment. Our cures may not necessarily come from drug companies, our cures may come from other places, and we need to be open to that and creating alternate routes that can supplement what they're doing. It could be one day that a drug company will stumble onto a cure despite their best efforts. It could happen. You don't know. You don't know. Or it could be that we have a repurposed medication that was used well for another drug, but turns out to be our silver bullet. That would probably happen as a result of academia testing it. But it could be that our silver bullet will come from ultra-focused lasers, high-focused ultrasound. That's a technology they're investigating at the University of Virginia. It could be some microbiome answer. It could be anything. We need to be ready. And to be ready means that we need to partner with disease groups outside of the CCM field that have some commonalities on a biological level. And right now, those illnesses include cancers. They include eye diseases. They include gastrointestinal disease. There are body systems that we did not recognize before that share commonalities with us, and it could be that their best treatment turns out to be our best cure. We need to partner with government, with our government, but also with other governments, with industries like the insurance industry, who actually could get a good return on investment for a cure, in order to get things moving forward a little bit faster, and potentially with foundations. I know the Gates Foundation visited UVA last week, so they might want to be visiting some other institutions that are doing work. And then we need to fundraise ourselves to make sure we're prepared to fill in the gaps in the development of cures. So the takeaways here are, we're in a new era. The drug trials have started. There are 3 medications right now that are being taken by people that are potential treatments for cavernous angioma. Atorvastatin is being prescribed at the University of Chicago. Propranolol is being prescribed in Italy. And Temple just had, as you heard yesterday, its first in human phase 1. Somebody took it, put it in their mouth, swallowed it on October 24th. So this is amazing. We could not have imagined this. Well, we could have imagined it 5 years ago, but we didn't know what the timeline was. And the fact that they're 3 at the same time all started is just incredible. So new era. The era will mean better prediction, better non-surgical treatments, more informed care, and mobilized patients. And we move forward because of you and because of everybody there. I want to thank for the conference too, our board of directors, our scientific advisory board, Carlos, Greg, Tracy, who's upstairs, the Greater Washington, D.C. Community Alliance, all of the community alliances, clinical centers, and research labs, our donors, our volunteers, Stephanie, Amy, our families, our friends, everybody. I want to thank everybody because this has been the best year ever. Just so you know, it's been the best year ever. That's it.
Whenever you're done.
No, I'm done.
Oh, you are.
I'm going to do an AMA though. So yeah.
What do they do with the raffle?
First I'm going to pull a raffle ticket, and then if there are questions about anything from the last 2 days or any, like what's for breakfast tomorrow, whatever, I can try to answer. So the winner is, everybody got the ticket out? 099153. 153. Oh, come on, that person's not 9. Oh, Candy's still digging. I bet it's Candy. 153. Carlos.
163.
No, 153. I got 153.
Did you also draw yesterday?
No.
Oh, so I must not.
Should I go ahead?
Yeah.
All right. So Stephanie's go and draw somebody else. 099084. Over there. Irene's home. Congratulations. Yes.
So yesterday in our brainstorm group, did you want to hear what we wanted to discuss if there was time?
Yeah, if there's, sure. Yeah, I mean, like what you want to discuss.
Just actually, I discussed it yesterday morning also, but our group would really like to see a smart acts made to educate health providers on how we can purchase the app or maybe like bucks or something like that, but every smartphone has an emergency that they can hit, so doctors can open up their phone and use that. And all the information about CCM will be there, educated well. So that's for
Okay. So
and how Angioma
you can help develop apps.
Mm-hmm.
Anybody have any resources for app development?
You mean specifically